When sourcing the correct equipment for your veterinary procedures, there are 4 key things to consider. 1. Is the design suitable for the procedure at hand? 2. Is the implant material and quality to a certified standard? 3. Is the implant cost-effective for both the practice and pet owner? 4. Is the implant readily available for immediate delivery? The choices we make may also have an indirect effect on our environment and community. For example, many implants are made overseas and have to travel up to 10,000 kilometres just to reach the UK. N2 UK have the solution. Our high-quality range of veterinary products are manufactured right here in the UK, helping you reduce your carbon footprint while supporting your local community and business. With over 4,000 product lines in stock, each manufactured to meet quality ISO standards and next-day delivery available, we can guarantee the efficient delivery of your products as and when you need them. For a cost-effective solution to your veterinary needs, visit n2-uk.com today.
Evening everyone, thanks again for joining us and the third and final one in the series. As always, hopefully each talk will be useful in its own right, but if you need to catch up on the other ones, they're on the e-learning website, as Paul said, so you can catch up there. So we move through the aims for tonight, so we can look at complications, essentially as Paul said, complications and case scenarios, looking at what the usual complications are and the group of complications we can run into when we're dealing with fractures. And we'll talk about how we avoid or mitigate these complications. And then we're going to do some 3 case scenarios to go through at the end, just to summarise the fracture assessment score and construct design and how to approach some of these cases. So despite everything we do, complications will occur in some of our surgeries, and they always make your heart sink when you see them on the x-rays or the patient with the fracture repair that's come back 6 weeks after for a recheck and it's just not going as well as you think it should be. And when we're looking at orthopaedic surgery, what do we consider a complication, or how do we classify them? It can be variable. If you read in the literature, you can see it varies, but there's a defined set of criteria with the reference at the bottom there, with minor complications being ones that occur but have little impact on overall result, so you don't need to intervene. So any complication that doesn't require an intervention for a good outcome is still minor. Major means you've had to do something about it, either medical or surgical, and that can be where it's slightly different. Some people consider surgical intervention major and medical minor, and catastrophic means that we've got an unacceptable function, permanent disability, or even death or use of euthanasia, and that's sort of the way we'll consider them for orthopedics. So complications in general can be divided into general. Any surgery has potential for complications. Orthopedics has a component of soft tissue surgery as well, so that still stands, as well as technical, mechanical and biological complications with the fracture repair. And often they're not exclusive to one category, they can intermingle, and we'll look at that in a little bit more detail. It's important that if we run into a complication, it requires critical appraisal. A lot of time in orthopedics, it falls at the feet of the surgeon to look at why the complications have happened and to be really critical of yourself and considering why it's happened. Generally like to think if you can't find a cause for the complication, then look harder. They tend not to spontaneously happen. You may not have known about it at the time, and it may be in retrospect you understand it and that helps you learn, but it is important to be critical and look back on these things. So general complications, we said, surgical site infection, not just with the bone and the implants we'll talk about later, but the skin, the surgical approach to the fracture site, dehiscence or problems with wound healing, iatrogenic damage to the musculoskeletal system or neurovascular, especially ligaments, tendons, and some of the bigger veins and bigger nerves that are running through the approaches can be damaged. We'll talk about sort of specific joint complications as well. Being aware of where you are and where you're operating is really important for orthopedics. And of course, there's anaesthetic related complications that can go along with this. So if we look at the first group of technical complications, they're invariably due to a failure in the surgical judgment or the technique. So it's damage to the patient or the implant. So we put a screw into a joint, we've crossed a fracture line, we've placed our implants too close to a fracture line, we haven't made our screws long enough. All of these sort of things are complications that may come back and haunt us. Example there, TPLO of mine, that the top screw was not long enough. The dog had a little bit more activity than it needed, and we saw an implant failure there. It did go on to heal without any further complications. So it was a good result in the end, but it's important to consider that. Inappropriate implant placement. So as we said, if you're putting things too close to joints, you're running into the fracture line with your screws, or you can't get enough screws above and below the fracture line. These are more likely to lead into a complication. And how you decide to fix the fracture: wrong size plate, wrong position for your screws to go in, using a too small a lag screw, or not lagging the screw in using position. All of these things can catch up with you. And once you've got one of these variables in play, rectifying it can be a lot harder after the fact, and not until we've got more problems than we started with. And that's why we see these unseen technical failures leading to mechanical failures of the implants. So the best way to mitigate that is to make a well-planned and executed surgery, and to respect the principles of fracture management and the surgery, and making sure we're really comfortable with those when we get into the patients. So we now look at mechanical complications. So ultimately, it means an implant failure or bone failure, remembering that implants and bones become a composite material when we put them together. And they can be metallic fatigue, can be an acute overload of the bone or the implants. Corrosion of the metals and physical imperfections within the implants can be a problem. So we look at metallurgic failure to begin with, and due to imperfections, as I said before in previous talks, is rare in the UK. We've got pretty well-established quality assurances, and the manufacturers are making very good implants. So it's very unlikely that we're going to see an imperfection in the mechanical process, or the manufacturing process, that's going to lead to a mechanical complication. But you need to be aware of that when you're purchasing these things. You can get very cheap implants online, and perhaps been said before, cheap things are cheap for a reason. But if you haven't got a good quality material and it's not been made properly, you can see them notwithstanding the normal rigors of implant life. So purchasing implants with a good quality assurance is important, and I've got a picture of a copy of N2's one's over there, which is always reassuring to see in a brochure. So corrosion, this occurs because you're putting metals into a biochemical environment, and that means that they're placed in a solution with a pH, so that there's fluid, the electrolytes that are there, and all the solutes, as well as the variable oxygen tensions, not just along the entire implant, but at different parts of the implant, can all have an effect on its mechanical structure. We can see friction between other implants as well, so screws and plates that are put in together. So a plate screw will have an inherent friction with the plate itself, and that can cause corrosion issues. And we'll talk about these now. So galvanic complications, so reduction or redox reaction that occurs between two implant materials. We said before, if we're putting titanium screws in a steel plate, where the screws and the plate interface, we can see this reaction, and we can actually get quite serious loss of mechanical strength of one or both of the implants. Pitting or crevice corrosion, this is where we've got low local oxygen tension, so perhaps underneath the head of a screw put in into a plate, and this leads to the loss of the oxide layer, especially when we're talking about stainless steel, so we lose that protection against corrosion. Then, as we've said, we're in a biochemical environment that allows for the plate to start to corrode, or the screw or pins, etc. And fretting, and this is where you get two implants working together, so you get micromotion causing wear between the screw head and the plate. And if that's enough, you can then start seeing the screws becoming loose, toggling free, and seeing quite catastrophic complications. On its own, it's unlikely to be the only reason that we've got a failure or a complication for our patients, but they can exacerbate things leading to failure, so it's important to be aware of them. An acute overload, these occur when you've got a really high force suddenly applied very abruptly, so a lot of force over a short period of time, and the implant just can't deal with that. It overloads the mechanical structure. We see a rapid crack formation in the material, but generally speaking, the forces required to do this are greater than the forces required to fracture bone. Looking back in the first lecture when we talked about the strength of materials, we can see that both steel and titanium have a higher Young's modulus than bone anyway. So we tend to see plastic deformation of the plates or screws or pins more than we see a complete failure of the implants, but this still means that they're not able to do their job, and they technically have still failed. So an example of this is when we've got screw heads shearing. You put your screws in, you think it's going okay, and you keep tightening the screws up, and then suddenly you've got a screw head in it's still attached to your screwdriver that's completely come away from the shaft of the screw. Same can happen with wires. They bind on the bone, and suddenly the wire itself twists and breaks off. Or if we've got an inappropriate implant size, so we put a very small implant in a very big dog, then we can see that will undergo mechanical failure quite easily. And this example here, the last bit of failure of a plate opposite a small gap, you can see over here on the right of the screen that if we've got an implant system like this, where we've got a plate, and then this is being the fracture line here, and a gap, you can imagine that this is going to create a wedge effect, and the fracture is going to want to collapse away from the plate, and we can see failure through here. Whereas in this side, if we've got the plate up against the bone, and we've got the larger part of the gap spanned by the plate, then this column of bone is actually intact, so we're getting better mechanical sharing of the forces running through that fracture between the plate and the bone than we are in here. So we see the forces running through and coming up to the plate, putting this area under a high amount of strain, and more likely to see a complication with the plate undergoing mechanical failure. Fatigue failure, this happens over time. The best example for this is taking a paperclip, you fold it out straight, grab each end and keep bending it over and over, and suddenly you've got two halves of a paperclip in your hands. And that's what can happen with these implants. If they're continually loaded during normal forces, and if that continues over a certain level of force, we start to see micro cracks that propagate into fissures and then into implant failure. And this can be a reason why we see a patient recovering very well for a period of time, and sort of perhaps 2 weeks into the recovery process, having been sound, they suddenly go lame again, and that's because the implants failed. A good example of that is if we've got an exposed plate hole over a fracture, so no screw in the hole, and it's a weaker point in the plate, and this suddenly gives way after just undergoing cyclical loading over time. The time to failure is inversely proportional to the amount of stress applied, so the more force running through the plate more frequently is going to be a problem. It can be other implants, but this is something we definitely see with plates particularly. So keeping the patient still and considering the size of implants is important, but this absolutely shouldn't be relied on. There's only so much you can restrict a patient, and there's only so little force you can apply through those implants. The patient's still got to go outside to go to the bathroom, and that can be enough if we've got a problem with the construct system. Looking at the mechanical environment and the neutral axis of our fractures, so going back to that example we had a second ago with the plate on either side, it's just bearing that in mind when we're making our constructs and making sure that we're addressing the forces and not increasing the strain or stress to our plates or ESF fixation pins, K-wires, etc. Be kind to your implants. When you're putting these in, you don't want to be over contouring them, bending them back and forth, putting screws in with a lot of torque. You want to treat these implants nicely so that they will actually stand up to the job that we need them to do. The principle of stress concentration is also really important, and we'll sort of run through this with some pictures now. So if we've got a solid metal bar, so a rectangular bar of metal, we put it under a tensile force, we can see that the force is pretty evenly distributed along the red lines. But if we now turn that piece of metal into a plate, so we're taking that bar of metal and now we put some holes in there, which is where we're going to place our screws as we're using it as a construct, and then you apply the same tensile force, so it can be of the same magnitude. What you see is where the yellow lines are is that those linear stress forces can't travel through the plate holes, so they actually have to concentrate around the plates, and this is the idea of stress concentration. And this can occur, and sometimes the magnitude can be up to 1,000 times increased in the stress being experienced in a very small area of our implant. And this is when we're talking about the principles of a stress riser, either in the bone or in the metal. And it can be because we've damaged it when we're contouring the plate, or we put a very abrupt bend in our plate when we're contouring it. It could be that the screw threads or the screw holes themselves actually work as a stress riser in the bone. Holes in the bone that are not bridged can be stress risers, as well as ESF fixation pins and the pin thread interface. And in locking systems, it's the interface between the locked plate, the shaft of the screw that's exposed, and then the bone is also an area that we see stress risers forming. So going back to this is the same picture of my TPLO, and this is a different picture over here. This is showing us how we can see screws failing. So they can pull out. So this is a locking system that's failed. The locking screws have not left the plate. They're still exactly where they were. It's actually the bone that's failed, and that's come away with the plate. In non-locking systems, we can see screws toggling, so they loosen and then undo themselves over time, and then you end up with a very loose system, which exacerbates the problem. Or we can see them shearing. This is an example here with that proximal screw, and we've had the screw shear away. The screw in the bone has stayed stable, the head in the locking system in the plate has stayed stable, but that very small gap in between is what's given way. And other times we can see that the implants bend as well. So some mechanical complications, and again, it's about making a judgment of what implants to use, understanding how they work, how they might go on to fail, and therefore planning against that. So biological complications are the last in the category of complications that we've got. The typical 5 that you may see when you're dealing with fracture repairs is delayed unions, non-unions, malunions, so all the unions, osteomyelitis and fracture disease. Osteoporosis is something we can see as a stress protection with implants, but I haven't covered that because it's seen less commonly in our patients. So delayed union, this is where your bone and your fracture is healing slower than you would expect. So this is a relative complication. It's called a delayed union because you still expect it to go on to heal without intervention. So we don't think our implant's going to fail first. We still think that bone is biologically active and going to do the job of healing. So it's actually difficult to define when is this a delayed union versus normal but slow healing. And of course, there's going to be some crossover in that. If the delay leads to cyclical fatigue first, then we can see complications. Most of the time, these are something that you pick up on, and you just have to be aware of it and allow things to go on to heal in a more controlled manner. If we've got an inappropriate fracture environment, so a bit more unstable, or it's high strain at the fracture site that we haven't accounted for, or we've got systemic effects, the patient's on perhaps prednisolone for another reason, so corticosteroids, or has diabetes mellitus that we're concurrently managing. These are things that can delay healing anyway, or infection will delay bone healing. If we move from delayed to non-unions, this is where the bone has not healed and will not heal. So it can be an extension of delayed union, or it can be because of an initial problem that hasn't created a biological environment for bone healing. And these fractures are not expected to heal without an intervention. So we can't leave these, they're just not going to work. Invariably, we see patients that are lame. So a really good indicator is when you're seeing the patient back for a reassessment, you're expecting to see good limb function, and it hasn't got good limb function. We've got a persistent lameness. Perhaps the owner said it's never really got any better since going home, or we've found that it improved slightly and then that's dropped back, and we're now seeing a painful lame limb. Most of the time we see pain, but not always, but lameness is invariably present. We'll further categorize these into either viable or non-viable. The viable ones are biologically active, so it's the mechanical environment that's poor, that's not allowing that fracture to heal. The bone ends are active and they want to heal, they just can't because of the environment they're in. Or we can see the non-viable types, and this is where the biological activity is shut off. It doesn't matter how stable that fracture is, if the bone is not trying to heal, we're just not going to get fracture healing and resolution of the problem. So if it's viable, it's the mechanical environment we really got to think about the most, and if it's non-viable, we also need to support the mechanical environment, but it's the biological environment we want to look at. So we split these down into the 7 different types, viable on the left and non-viable on the right. You can see hypertrophic or moderately hypertrophic, and this is where the bone's trying to heal, it just can't get rid of the fibrous tissue in the middle because often it's the strain environment that is too high, that's not allowing the fracture to unite. Or we can see oligotrophic, where we're just not really getting any progression at all. There's not really any callus being forming, but the bone ends are alive and healthy. And this is just a crossover into dystrophic, and sometimes it can be hard to know the difference between the two, and they can present quite similarly and managed quite similarly, in fact. So dystrophic is those fracture ends that they're just not trying to heal. If it's necrotic, we've got a piece of necrotic bone or tissue that's in the way, stopping the ends from being able to heal, and we start seeing the bone ends healing over on themselves, becoming sort of a scar. Or we can see a gap. So if the fracture just isn't going to heal across a huge gap, no matter how well we've stabilized it, and then in atrophic ones, we start to see that the bone ends not only switching off, if you want to consider it like that, but also starting to die back and being resorbed. And they're always scary if you see those on a set of x-rays. So non-union management can be challenging. It's always a bit of a worry for these because we've had an initial fracture that has decided it's not going to heal, probably because of something we've done, either inadvertently or something that we should have done better. And we've got to identify and address those underlying causes before we're going to get these things to heal. Sometimes we can see delayed unions that we're monitoring, we're keeping an eye on, and they're just not healing, and we get further and further down the line. Never had an indication to start stepping in until then, because no surgery perhaps seems like the right option, or the owners are averse to further surgery when everything seems okay. And sometimes in fracture management, it's having that confidence to see what you're seeing on your x-rays and start jumping in before you have a problem, rather than hoping you don't run into one. And that's a really good thing to start thinking about, is if you don't think things are going okay, being confident enough to step in and help them on their way before you run into a bigger problem. If it's viable, primarily we're restoring the mechanical environment and any malalignment that might have occurred. So this normally means replacing the implants or making them stiffer. Sometimes that's adding screws in, but typically you're changing your implants. Often you don't need to debride back any of the callus. You try and avoid that unless it really is getting in the way of putting your new implant system in. And often it's in internal fixation with plate and screws that you're going to go for with these non-unions, because you need them to be there for a long period of time. You're using external fixators. These things are you're going to worry about them being durable enough beyond about 12 weeks, when the pin bone interface starts to break down and the external pins become loose. So internal fixation with plate and screws is what you really need to be looking for. Intramedullary pins are not going to resist enough the forces, so certainly we'll be using those on their own. If it's non-viable, then we've also got to support the biological environment, and that still counts for these oligotrophic viable non-unions. So we want to debride the non-vital bone back, or the bone that's just not healing at the fracture site. You then want to stabilize it with a graft, and you want to put it in compression. So you're really trying to create a compressed, stable fracture if you can. That's really the goal. And then you want to support that with a really durable implant system, so not looking to be putting an elastic system in or bridging plates, unless you've got hybrid compression on there and a nice a proper lengthening plate, so we've got no screw holes in the middle to make this nice and rigid. So once we've got the scary idea of a non-union the other way, malunions is something we can see, and perhaps if you're very fastidious and exact about things, you realize that we see malunions perhaps a little bit more commonly, especially when we're looking at minimally invasive surgeries or biological osteosynthesis for fracture management. But the important thing is that these are functional malunions, and the patient compensates readily. It causes little to no impact on their function overall. Malunions can be angular, torsional, or translational, or shortening, and it tends to be problems that the patients suffer with more is when we see angulations that lead to joint angulations or rotations, so torsions, and this means that they're not able to compensate. We put the supporting structures around that joint under more stress, and often on one side, so leading to chronic ligament spraining and straining, and then we end up with degenerative joint disease. We can see joint collapse, especially in the carpus. We can start seeing that collapsing away, and the paw strikes the ground in an abnormal position, and you may see secondary skin lesions as well. So functional ones are common, but it doesn't mean that we have to accept them and can get away with them. It's making that judgment and understanding that a slight malunion with a minimally invasive approach is okay, but we're not looking to be lax in our technique. We should be striving for normal union where possible. And then if we look at osteomyelitis, so this is technically inflammation of bone cortex and bone marrow. And here we see it as being almost always bacterial. Can be fungal, but in the UK we see predominantly bacterial osteomyelitis. It can be direct or traumatic, or it can be indirect or hematogenous. And normally it's because we've come along as surgeons and we've put something in there, we've fixed a fracture, been operating in a joint. These sort of things are leading causes for osteomyelitis, because normal healthy bone is reasonably resistant to bacterial colonization. So we need to have some factors in play for osteomyelitis to occur, and the principal thing is that we've got enough bacteria relative to the local environment and the host situation that it's in. So there's no single number of bacteria that you would need to exceed to definitely get an osteomyelitis, because going back to the previous example, if we've got a patient with diabetes, perhaps the amount of bacteria it would take to get an established infection would be less than a healthy patient. You need to have avascular cortical bone and an environment that favours bacterial growth and fracture repair. That's normally because we've got implants, we've got a fracture hematoma, there may be some necrotic tissue, and this is why we see biological complications or osteomyelitis in the more high energy fractures, perhaps if we've lost soft tissue, or in the areas of the body where we have low soft tissue coverage anyway, such as the tarsus. Promotes this environment that bacteria can take advantage of, and we then start seeing this established infection. It's responsible and understanding the fact that bacteria are nearly always present at surgery. Even if we have strict aseptic technique, we have to understand we cannot remove every single bacterium from the operating theatre and the patient's skin. The deeper into the skin before you move into the subcutaneous areas, you will still see some bacteria. The idea is that we've got those down to such a low level they're not going to cause a problem, but if we have a problem that allows that bacteria to take over, then we can see an infection. And this is why you get this term, a race for dominance used, and pretty much the immune system wins this, because the bacterial numbers are so low, we've got a normal healthy immune system that it can handle any ones that have sort of slipped through the net. But it's important to understand that as a principle. Bacteria can then find ways of evading the immune system. If we've got an implant and hanging out around that, the immune system can't get into metal, it can only get us so close. So if bacteria can hide further away, the immune system can't get at it. Biofilm formation is a big thing with osteomyelitis and implant-associated infections, because these bacteria create a matrix in which they're embedded that allows them to stick to each other. So instead of single bacteria, there's now starting to work almost like a team, and they're embedded in this sort of substrate or film that allows them to be very resistant to the immune system and antibiotics. Once this biofilm is established, you can't get antibiotics into it, and you can't get immune system into it, and this allows the bacteria to persist. They can become quiescent, so they sort of slow down, they stop multiplying, but they're still alive, and they can also start sharing resistant genes, and this is why we can see that we sometimes have to take implants out, or we can see late-stage infections when we put an implant in. So perhaps everything goes okay, fracture heals, and patient's doing well, and then it comes back a period of time after, a few months maybe after, and suddenly everything looks like there's an infection and we can't quite understand why. So that's important to understand as well. If we've got cortical bone that's involved and it becomes avascular, then we can start seeing sequestrations and involucrum formations as well, and we can pick those up on x-rays. If we wanted to prevent this, then making sure we're appreciating our patient, understanding any comorbidities that might create a problem, and making sure that we fix the fractures appropriately. If we're starting to see loose implants, recognizing that we need to address that, and if we've got a situation where we've got an established osteomyelitis, you need to replace the loose or non-functional implants. You've got to get good stabilization of that fracture, treat it with culture-directed antibiotics, and it's quite likely we're going to need to be taking the implants out after we've got successful healing. And if we can control it, we would expect to go on to see healing, but it can take absolutely ages. You suddenly have a fracture, you'd expect to be no longer causing yourself and the patient any problems after perhaps 3 to 4 months, to taking a year to be no longer a problem and the patient back to normal. And there can be collateral damage, and they may never get back to fully normal or as good a function as we'd expect if we didn't have the infection. Lastly, we'll look at fracture disease. So this is when we've got suboptimal function in the limb after fracture healing. We start to see changes in the soft tissue, so we get very excited about what we can see on x-rays. We've got bone, we've got implants, and that all takes our eye, but it's the muscles and all of the soft tissues around that we need to be aware of in the patient's limb for them to have a good function. So we see the muscles die back, get an atrophy, we can sometimes see contracture, we can see reduced joint ranges of motion, and in some cases where we've got articular fractures, we can also see degenerative joint disease as well, which can add to fracture disease. The risks for fracture disease, the age of the dog, younger dogs, we see this more commonly. So the most common is a young dog with a femoral diaphyseal fracture, but generally speaking in long bones. If the stabilization that we've used promotes for prolonged joint immobilization, so we've casted the stifle, we put a transarticular fixator on, or we've used an IM pin that's going to mean that the fracture isn't healing as quickly as it can do, and that the patient isn't using the leg as well. All of these things lead to compounding the issue, and we can start seeing quadriceps contracture if we're talking about the femur, but in any long bone fracture, we start to see that we can see the soft tissues involved as well, and we're getting this fracture disease complication. Pain control is really important as well. We need our patients to be using the legs or the operated limb pretty well after fixation and pretty soon, because that promotes healing. Going back to Wolff's law, that promotes remodeling of the bone once it's started healing, to making sure that we can go back to normal function. It doesn't take long. So if we immobilize a limb, we can see changes in all of those soft tissues, so not just those muscles, in as little as 3 weeks. And if you catch it early enough, it can be reversible and corrected, but if you don't, it may actually become irreversible. So this isn't something we can always effectively treat. Quadriceps contracture is a very good example of that. If it becomes well established, it can be disastrous for the limb and the patient overall. One Once we've got the muscles under atrophy and contract, we see loss of the normal stimulation and antagonism of the muscular pairs, if we break it down simply. So we can see them becoming fibrotic and not able to contract. Fibrous periarticular tissue starts to form, and we can even see adhesions between the synovium and the cartilage. Cartilage starts to atrophy. Once it's atrophied, it begins to ulcerate. We can see ligaments around the joint starting to break down. So all of this compounds the issue, and we've got a sort of a snowball effect going on. And as we mentioned with Wolff's law, we can see that we've decreased load through the bone, so we lose the mechanical strength of the bone, and that's not replaced at an equal rate. It's about 1/10 of the rate that it was lost, and you may never see that fully returning in a patient. And we can also see growth disturbances of the bone, malunions presenting as well. So if we want to prevent fracture disease, you need to be preemptive about it, understanding good fracture management, adhering to the principles. And like a lot of these complications, that's a big part of avoiding them, and making sure we're keeping an eye on these patients and intervening really early if we start to see anything that we're suspicious of as being a problem. If you've got to coapt because you're supporting your primary repair, or you're feeling that that's going to be your option, it's got to be the lowest time possible. Preferably you're putting joints in flexion, and this prevents so much of the soft tissue changes around the joint and in the antagonistic muscle pairs, making sure we're changing that coaptation regularly to keep an eye on what's going on. Physiotherapy is really important. Early stage physiotherapy would be ideal, and making sure these patients have got plenty of analgesia so they're comfortable in using the leg. As we said, quadriceps contracture is the biggest example there. We've covered most of the parts of it. What it leads to is inability to flex the stifle, so you've got a extended pelvic limb, medial patellar luxation, hip can subluxate, you've got osteopenia of the bone and femoral torsions. You see these guys with straight legs sticking out. They're almost like using them like a crutch rather than being able to actually walk on them. It's very hard to treat that, and the prognosis is very poor. If it's early, you might be able to, but it's got to be pretty pretty aggressive intervention, and a lot of owner sort of involvement as well. And that's why we tend to see these things being such an issue. Cats may have a reasonable function, but that's a big may, and will be on an individual basis. So overall, with complications, so rush through those is a scary part of fracture management, but being aware that we can run into them and being able to recognise them and recognise how they present is important, because the earlier you detect them, the sooner we're going to be able to do something about it. A complication rate of 0% would be ideal. Perhaps that's the holy grail, but we need to be aware that that's unlikely. So we have to make owners aware that there are potential for some serious complications when we're dealing with fracture management, and make sure they are fully aware of that before we go ahead. And although we might not be able to get 0%, we've always got to be aiming for that. We shouldn't accept a level of complications if we think we can make it better or avoid them. And always, it's got to be a point for reflection. If we run into that complication, think about why perhaps it happened. You might not have been able to change anything at the time, but if you can change it for a future patient, then that's really, really important. Achieving a good outcome after a complication is possible. There is certainly a high risk that we will not get as good an outcome, or we could end up with a bad outcome with our complication. But it can be challenging, and this is why the first repair is always the best repair if we want to get it over and done with. Because if you've started to lose bone stock, you've got an autobiological environment where you've got secondary changes in the limb, we've got an infection. All of these things are going to start making that repair a whole lot harder than it was to begin with. And avoiding a complication is, of course, the best way to manage those. So we're going to run through a few, hopefully relatively simple case examples now. Preoperative x-rays of all of them, so we'll run through them now. That'll allow us a chance to look at the fracture assessment score and sort of recap everything that we've discussed in the series. So this is from the first few slides here from the first talk we did, so looking at our patient flow chart, and we're going to come along at the level of sort of a full history and examination and getting on to fracture managing. I've picked examples where these guys have actually been very stable when we've seen them and they've been transferred, but not forgetting that that may not be the case. And just to remind us whether we're thinking about reconstructing these fractures, it's can we reconstruct it, and if we can, should we? And that will be a big governing influence on whether we go with a anatomic reduction and rigid fixation or a biological method for repairing these fractures. And then finally, the fracture patient assessment score. So remembering that if we've got a low score, that's not a good thing. Ideal situation would be highs across the board. And when we've got a high score, we're expecting the fracture to heal with less complication. We need to do less intervention to get a good outcome. And if we've got a low score, we're really starting to recognise that this is a poor environment for fracture healing, and we've got to support it and be aware that this is more likely to have a complication. So we'll run through the first case now. So we've got a 6-month-old male Daxi. This guy jumped from the owner's bed and suddenly went acutely non-weight-bearing lame in his left pelvic limb. He's otherwise vaccinated and well. He's fed a normal diet and he presented reasonably soon after the incident. He's not got any reported comorbidities, and the referring vet has given some opioid pain relief, but apart from that, he's not any. And his function is to be a beloved family pet. So if we look at those, green being good and red being bad, he's a young dog. That's always going to work in our favour. I haven't highlighted the part that he's a Daxi in red. That's going to be an important consideration for anatomy. Jump from the bed, so it's not a particularly high level of trauma for this fracture to occur. That's both good and bad. It starts to just raise that suspicion in your back of your mind that perhaps it was an underlying issue. So just bearing that in mind. But he's also jumped from bed. So he's a small dog and a bed is quite high for him. Whether he's got concurrent, perhaps cranial or facial injuries or in the thoracic limbs as well that aren't as evident. Presented 24 hours after the incident, so it's early. He's on a proprietary diet, so chances of this being nutritional, so a pathological fracture first, are less likely, but we won't rule that out completely until we've looked at our x-rays. It's got no comorbidity, so that's excellent. And then finally, in function, he's a beloved family pet. That normally means you're going to get good owner compliance because they're really invested in getting a good outcome, but it also means that they are pretty bad in experience at actually letting these guys be cage rested because they spend a lot of time cuddling these dogs and they live in their arms a bit, and a big part of the family. So that's where the compliance can start to fall down. So just recognising that. So 3 points from that, as we said, is small dogs jump from a bed. Has he got some injury to his front end anywhere? Specifically the thorax, the head, or the jaw, and given his signalment, is this neurological? He's a young Daxi, it's unlikely, but it's important to be aware of. So we'll just summarise that. The routine physical examination, there was nothing particularly troublesome on his routine exam. He had a mixed dentition, which was about appropriate for the age, and there was no other concerns raised or present. His orthopaedic examination, he did have external coaptation on, so can do a full assessment of the limb conscious, but he was non-weight bearing anyway. You really want to put that leg to the ground, even with the bandage on, unless he was sort of standing and just gently resting that on the floor. No evidence of neurological, spinal, or thoracic limb problems, or the head. I put that in there, but that was all fine. Bilaterally, he's got carpal valgus, which perhaps is considered normal for the breed, and at the moment is not causing many problems. Superficial sensation in the digits, we know you can feel them, so less issue of a neurological or vascular incidence to the leg as well as the fracture, and palpably swollen and painful. So all looking relatively straightforward, which is good, and we're going to put some differentials on there. It's a fracture talk. We know this guy's got a fracture in hindsight anyway, but important to, when you're looking at these guys, just being aware that it could be a traumatic fracture as we're anticipating, or Salter Harris in this young dog. Could be pathological, could be nutritional, could be that there was a congenital bone defect or a congenital issue that's led to weaker bones. Is it the tibia or the tarsus? So we've got a tarsal instability, so a joint issue rather than the fracture. Is there an underlying osteomyelitis, cellulitis, abscessation with the swelling that's led to this fracture? Unlikely with the history. And being a Daxi, was it an underlying pes virus? And actually that's what's the primary issue there. Then you go on to your investigations. Sort of a brief blood screen was all normal. Then we do the static examination and the x-rays. You may want to consider CT, but in this patient we didn't think it was appropriate. Bloods were all within normal limits. Static exam confirms we've got tibial instability, tarsus is fine, there's no open wounds, and the joints above and below are stable. So then we go on to take our x-rays. We've got the contralateral side for comparing, and standard orthogonal views showing our fracture. So then we define it, going back to that first talk, and this table with the reference there. We've got a left tibial diaphyseal complete spiral, minimally displaced closed fracture with no evidence of bone disease. So if we go back to that, we can see that its fracture line is evident, but it's not vastly displaced. In the medial lateral view, we can see the fracture line prominently here, and in cranial caudal, we've got a little bit of displacement laterally, and the fracture line running through there, and we know it's spiral because we can see sort of the two halves of it running through there. So looking at the assessment score, So firstly, running through these in simple order: mechanical, biological and clinical, and start thinking about the mechanical score for this dog. So he's a small breed, single limb, simple fracture, and there's no other issues going on. So he's going to start looking towards the higher end, and it is reducible. So for these guys, it'd probably be a nice 8 to 10 score from the mechanical point of view. Biological, it's relatively low energy, but it is a diaphyseal fracture and it spans a large amount of the bone. We're in an area where we've got a moderate amount of soft tissue, and being a young dog, we've got that as well, but it's not a proximal limb fracture where we've got lots of soft tissue coverage. We're not going to be doing a closed reduction, so we need to do an open but relatively limited approach would be fine. So we're starting to see that just slipping down a little bit. Still a high score, but just being aware not to get carried away, just giving him highs across the board. And as we touched on earlier from the clinical point of view, although the dog's pretty calm, I'm just a bit nervous that the owners are not going to fully adhere to the cage restriction. We already know this little guy likes to be on and off beds and is able to jump on and off them. So that starts to just make me a bit nervous. So looking at the fracture, is it reconstructable? So yes, we're going to need interfragmentary compression to get that. Are we going to achieve that with a compression plate? No, because of the fracture configuration. So we need to think about using a lag screw or screws. Biological options, we could look at external fixator, but it's a long fracture line. So we've got bone stock either side, and we're going to have owner requirements, and we've got a patient with the anatomy where we're more likely to get complications with the frame rubbing up against the parts of the body, perhaps being uncomfortable, so we'll probably avoid that if we can. Bridging plate, you could put a bridging plate in there, but it is reconstructable, and if we're opening to put a plate in anyway, then perhaps a bridging plate is not going to give us the compression and the direct bone healing that we'd want. Can get interlocking nails. It's a small patient, as you remember from the X-rays. We've got a very big metaphyseal component, which is common for these guys, proximally in the tibia. So angling the interlocking nail and getting one of a good size into this patient might be challenging, and whether we've got one or not, of course. Non-surgical is a small chondrodystrophic dog. We're worried about compliance. I'd be a bit nervous about casting him personally, so we're not going to look at that. So what did I come up with? Put a lag screw in, so we're getting that interfragmentary compression. Then we're putting a neutralization plate alongside to support that. Can put it in hybrid, so not necessarily compressing, but with cortical and locking screws. Moderate bit of contouring. We're using a locking system, so it doesn't have to be perfect. And a relatively sympathetic approach. I used the 2-4 system for this little guy. So we look at this with the 4As, going back to the previous talk, we've got our lag screw in there, and if we look on the orthogonal views and we're looking at hiding around the implants, you can see pretty good compression of the fracture line. There's still a bit of evidence there, but it has compressed nicely, and the screw's doing a good job. Plate, going to be critical. The distal screw is monocortical. It's very close to the joint. It's a fixed angle locking system, so it can't angle away from there, and that's why the second most distal screw is perhaps a little bit on the short side. And contouring, these guys are young, have a lot of periosteum and soft tissue around the bone as well, but could have been a little bit better contour perhaps proximally, so being aware of that. Otherwise, fracture fragments are well aligned, and we've got good alignment of the joints and the bone above and below, and the apparatus looks otherwise good. We have got open screw holes through the middle there, but we've got interfragmentary compression with our screw. This is a young dog with a number of screws in there. This should be a strong implant system for him. Good. We can't look at activity because that's immediately post-operative, and this went on to heal very well with no complications. So case 2, we'll look at a Salter-Harris fracture. So this is a 10-month-old cat. It's been outside. We don't know what it's done, but it's come home and it's now not able to use the leg. The owners have kept a close eye on it overnight because it otherwise seems pretty bright. Hasn't resolved, so taken it to their vet. And then this has come over from the vets themselves with a small soft tissue wound noticed on the distal lateral tibia, not weight bearing on the leg, and a bit of deviation that they've noted as well. This cat's also otherwise healthy. There's no other issues. The referring vet's given some opioids and some non-steroidals. And the cat is just a happy pet with outdoor access. So greens and reds again, young animal, that's always good. We've got unobserved trauma, so we just don't know what might have happened, just being aware that this could have been an RTA and a high energy and polytrauma case. It's presented relatively early in the course of things, and it's managed to stay stable with minimal intervention at home. We'd encourage that, but looking back and having that to hand makes us feel a little bit more comfortable that this cat is managing well with the systemic effects of its fracture. We have got a small soft tissue wound, so whether this is a contaminated fracture, being an outdoor cat, if it starts going outside or longing to get out of its crate, just bearing that in mind from a compliance point of view as well. Points to take from that: it's unobserved, it's polytrauma, high energy. When did it actually happen? These owners seem pretty diligent, so it probably was just within that 24-hour time frame, but sometimes we see cats that have been missing from the household for days on end, and then suddenly they reappear, so we don't know quite how long that's been. And we've got a soft tissue injury, so is this an open fracture or is this just a concurrent small soft tissue wound? So again, physical examination for this patient was pretty unremarkable. The orthopedic assessment shows we've got a marked weight-bearing lameness of the right pelvic limb. It's starting to deviate to varus under weight-bearing, so we've got instability. No other issues. The sensational reflexes in the limb are all normal, and there's a small superficial wound over the lateral malleolus, and there's quite a lot of bruising in the leg as well. So got no other issues going on, neurologically normal. We've got a moderate right pelvic limb lameness, and we can see that that's unstable. Again, these differentials, yep, it's going to be a fracture. That's what we're here for. But just being aware that how did it happen? Was it purely traumatic? Did it get the limb caught falling off something? RTA, bite or a fight with another animal? Is it pathological? Could be tarsal fracture luxation. It's very distal, this fracture. It could be an angular limb deformity that the owner just hasn't been aware of before or hadn't thought to mention, or whether there's a congenital abnormality. So again, sort of a minimum database, sedated exam and x-rays. Bloods again were all within normal limits. There's medial lateral instability of the distal tibia. There's no open wounds communicating with the injury, but there's a very small 0.2 millimeter diameter wound there. 2 millimeter diameter, 0.2 centimeters. And distal tibia palpable. You can feel that cranial to the foot. So these are our X-rays. Orthogonal again. We've got a survey X-ray of the abdomen and the thorax as well, on the contralateral side for comparison. So looking at that, we can see distal tibia. We can see that there is just a little bit of tibia attached to the tarsal joint or the tarsal joint. You can see this sort of interdigitating appearance here, typical of the growth plane, the location. If we compare it to the normal left medial lateral view, we can see that is through the physis there. So that helps us classify this as a right distal physeal Sauter-Harris type 1. We haven't got any metaphyseal component involved, so it's just straight through the physis, caudally displaced, and it's closed, having looked at that small soft tissue wound. So again, giving this a score mechanically, we're going to give this a relatively high score. It's a simple fracture. There's no other issues. It's in a single limb. It's definitely completely reducible. Biologically speaking, it's low energy. It is physeal. It's very distal. It's in a cat distal tibia, so we know that the blood supply there can be a bit of a challenge for fracture repair. But we've got the fact this is a young cat on our side as well. And then from a compliance point of view, owners are pretty keen. The cat's a very nice cat. Doesn't seem to be too worried about its fracture, surprisingly. So we're not so worried. So this has got a pretty high score. So we're feeling pretty good about using our standard implant system for a Sauter-Harris fracture. So is it reconstructable? Yes, but no, we don't want compression. So we're not looking at screws and plates to cross the fracture line, because we've got that physis there. So technically more of a biological option. Cross K-wires, we could use rush pins. You can use an intramedullary pin, but given how small that fragment is, that's really not going to be something we're going to try and do, and you're going to be in the tarsal joint, so that's off the table. Your ESFs, if you were thinking about that, would have to become transarticular, and why start immobilizing the tarsal joint or the tarsus itself if we don't need to. It's non-surgical, it's juxta-articular, excuse me, and there's not a huge amount of intrinsic stability, so coaptation is not really going to be appropriate at all. So, as you may expect with a Sauter-Harris fracture, crossed K-wires is the implant design on both sides, using a pretty sympathetic approach to just respect the soft tissues, being aware we're working near the joint line, so we don't want to become intra-articular with the placement of our implants. So there's the before and after shots. So we can see in the all the way over there on the right, the craniocaudal view, that we've got nice crossing of the K-wires. They cross above the physis. We've got two medially and one laterally. and they cross nicely. Fracture fragments for apposition. If we look here in the medial lateral, it's not a completely perfect reduction. Whilst that gap is small, that could have been better, could have been a bit more reduced. This has gone on to heal okay, but it's an important thing to be aware of, so we're being honest about that. Alignment of the bony column and adjacent joints, very happy. I have cut the stifle out of these x-rays to make them fit, but we're happy that everything lines up and we haven't got the fracture reduced, but the tarsus pointing off, or the Pez part pointing off outside of the body. Apparatus, so we had to look very closely here using the two views to compare them, because otherwise we'd start to worry that this second KY might be intra-articular. It's not, it's this one passing here, so it does pass outside of the joints, superimposed over the joint line rather than through it. So otherwise happy with the apparatus there. And again, this went on with no problems. You can see that the tips of these pins are very close to the skin surface, and we can quite often see if these pins migrate, or even if the pins themselves start to rub through the skin, that this can be a secondary issue and necessitate the pins being removed in some patients. So finally, we'll quickly run through a distal radius and ulnar fracture. And this is a 2-year-old female Yorkshire Terrier. She's jumped off the bottom step of the owner's staircase while playing, suddenly gone lame on the left thoracic limb, and she's completely non-weight bearing lame. She'd previously been seen for a traumatic brain injury, which resolved with conservative management. The dog was struck on the back of the head and went a bit ataxic, and mentation was reduced, but this rapidly resolved on presenting to her vets, and they haven't seen any issues since. Again, opioids and non-steroidals. This is a pet, but the owners are very risk averse, and they've got really high expectations for the outcome. So, got a toy breed dog. It's jumped from the staircase, so it's a low energy fracture. So these are all good things. Risk averse and high expectations in the owner is a red point there to think about. Probably that previous comorbidity as well. Just being aware of that before we're looking at anaesthesia. So it's an observed trauma. There's no comorbidities. It's relatively low energy, but is it pathological? Is always going to be something we think about. Soft tissue injury, it's unstable, so is there ongoing injury to the blood vessels, the associated soft tissues and nerves there? And we've had that previous injury that we talked about, so is this concern for anaesthetic? So apart from being inseparable from the owner's arms, this dog was otherwise well in itself, and pretty standard examination. When we did get it down onto the floor, the dog was pretty reluctant to move around and completely holding the left thoracic limb off the floor. There was a little bit of angulation, virus of the distal antebrachium, and a lot of swelling considering the patient's size, with a lot of bruising, but it did have normal sensation reflexes, so the limb looked certainly viable with no neurological components to the injury. Neurologically normal in the limb. It's got an unstable fracture, but it looks like it's low energy, and it's in the distal limb, so we're not too worried about thoracic or abdominal injuries. No other comorbidities, and the owner reports that although the previous mentation had been altered, it did rapidly resolve, and that's been a consistent period of time since occurring in presentation for this case. So again, differentials, fractures again, carpal hyperextension in these young dogs. Perhaps it's osteomyelitis that's gone undetected, and looking at the other issues of whether we've got atlantoaxial instability or some sort of forebrain issue as well. Blood results were normal. Cranial nerve exam was normal, and there were no further neurological concerns for this patient. Carpus itself was stable when we looked at the fracture. It was palpable distal radioulnar defect with moderate bruising and swelling, and the valves that we talked about. So survey and preoperative x-rays, having a look at the neck just to screen for atlantoaxial instability, not to exacerbate or try and flex or hyperextend the neck in these little guys, because if it's there, you can suddenly make that very, very bad very quickly. Getting our contralateral views, we've got an IV catheter in the way there. It doesn't always look great, but good IV access for us. You can see those bones are pretty small. Looking at our radiographic marker there in all of those pictures with the scale on there, you can start seeing that there's not a lot of bone. Then when we look over on the left with the fracture, you can see there that it's distal, but it's not as distal as they can be. So there's a little bit of good bone stock to take advantage of in the distal fragment of the fracture. So it's a left distal radioulnar diaphyseal transverse fracture, and it's got some quadrilateral displacement, and it is closed. So again, looking at the score, It's a small breed dog. It's a single limb. It's a simple fracture. There's no other issues that we can detect going on, and it is reducible, so we can start to give that a high score. It is diaphyseal, it is distal, so that's going to be something to be aware of. Biologically speaking, it's going to be a bit lower. It's a distal radioulnar fracture in a toy breed dog, so we start to know that these guys can be running into biological complications with the healing process. It can be slow healing or non-unions occurring. We start losing support of the ulna pretty much regardless whether that will heal or not at all. So we just need to be aware of that. And compliance, again, similar to the first patient, this is well loved. It spends a lot of time at chest height being attached to the owners, so just being aware that they're probably not going to be keeping it in a cage, or there's a risk that if they've got it out and it slips out of their grip, we could have a problem. So is this reconstructable? Yes. Do we want to reconstruct it? Yep, pretty much. So interfragmentary compression, we can't put a lag screw in. It's a complete transverse fracture. So we need to be doing that with our plate. So we need to be getting really good reconstruction. Biological, you can put ESFs on these. It's challenging. Free-form ones are certainly described, as well as circular or hybrid ones. If we want to get compression, then not putting the ESF on there for obvious reasons. But it is an option in these guys. Bridging plate, it's going to be a high strain environment, so we're probably going to avoid that. Intramedullary pin, as well as cast, these are absolutely contraindicated for these types of fracture. In a toy breed dog in that location, you don't want to cast, and in the radius, you don't want to be putting an intramedullary pin in. We're really going to almost guarantee you'll end up with a complication if you do either of those things with a pretty high level of certainty. So what do we go for? We put a hybrid compression 2mm T-plate on here, with the shape plate allowing to get screws grouped together in a juxta-articular position. Caudal screw placement for our dynamic compression, so they've got to go in first, and they've got to be into place, got to be well contoured. Locking screws to enhance our holding durability for this fracture. Not looking to fix the ulna. Would do in perhaps working dogs, certainly in cats or larger individual dogs, or if we've got a really low fracture assessment score overall, you can start thinking of putting an intramedullary pin in there. So before and afters again with the implant on there, again being critical. So looking at the apposition, we've got pretty good apposition. If we look here, this is the non-stabilized ulnar fracture, and there is just a very small gap there. So this isn't completely perfect reconstruction, but that's a very small gap, less than 1 millimeter. So we're going to achieve that direct bone healing. The alignment's good. We're happy that the joint alignment was anatomical, given that reduction as well. If we're looking at the apparatus, there are a few things of note there. That this screw is perhaps a little bit on the long side, perhaps a little bit close to the fracture line. Again, this has gone to heal okay. That screw being close to that fracture line, when you magnify it up and measure it, it's just within the level of tolerance, but it is very close. And I've been much more comfortable if this plate was even a few more millimeters distally with that screw there, but it hasn't caused the patient any problems, so that's good. But if we had a technical complication, that could have been a reason why. So there's a list of some of the references from the earlier in the talk about complications, and that brings us to the end and opens us up for any questions if you guys have any.